Hi, this is Robert McMullen, and I'm going to talk about OCD and the medication treatment and the TMS treatment of OCD. It was just given FDA approval to treat OCD with the BrainCare TMS helmet just 2 weeks ago. I'm Robert McMullen. I'm a psychiatrist. I've been in practice over 30 years. I went to Washington and Lee undergraduate. I went to Georgetown Medical School, and I did my residency at Columbia. And then most of my life, I've just done psychopharmacology. I've also worked in the facial pain clinic at Columbia, and for a year, I spent a huge amount of time working with AIDS patients in '86. But mainly I've specialized in diagnosing and treating or referring people who need pharmacological treatment for their psychiatric disorder. And then 8 years ago I added TMS, transcranial magnetic stimulation, which is something I just had to do because some people, you're stuck and you can't go any further except to shock treatment, and this TMS often works. Now what I wanted to talk about right now is OCD, obsessive compulsive disorder. This is sometimes called an anxiety disorder, but it's controversial, and many specialists don't want to include it among the anxiety disorders because in some ways it doesn't fit. For example, the medications that work the best for it are the serotonin medications. Prozac, fluoxetine, Zoloft, sertraline, Celexa, which is citalopram. Those work the best, and the very best is anafranil clomipramine. And the anti-anxiety agents don't help out much. You would think that they would help out, but they don't really help much. With other anxiety disorders, the benzodiazepines are often giving them immense relief of their pain. Once in a while you have people with OCD that the benzodiazepine does form a major part of their treatment to reduce their pain. But the benzodiazepines don't actually help them reduce their symptoms much. The symptoms of OCD are very variable. Sometimes they can be that you have to touch something 5 times on one side, or something will go bad that day, and in the back of the mind, or sometimes in the front of the mind, people will feel if they don't do some ritual, then someone in the family will be harmed. This also could be related to hand washing, which is a very common one, and it's got a more direct connection with harming people. That if you feel that washing your hands helps protect your family from being infected, then it's easy to escalate the amount of time that you do this. Now there's an odd thing about the OCD behavior, is that the more you do it, the worse it is. You would think that if washing your hands for 5 minutes is going to calm you down, then washing for another 10 will do it even better. But what happens is you're somehow rewarded by doing extra things in the OCD ritual, and then it just mushrooms and you have to do more and more and more. So actually, the treatment is to abort the behavior. And if it's a touching behavior, a checking behavior, or a hand washing behavior, it's not that difficult to do that. Now, it might be torture from hell if you have to do it yourself. If you get directions from the therapist about what you have to not do, sometimes it's just terrible, hard therapy, depending on your OCD. But it's possible to just simply not let yourself do it, or even better is have a relative or the therapist or a spouse have you go ahead and wash your hand for 1 minute and then force you to sit on the couch and you can't do any more washing. Now the anxiety is going to go up. So if you can't wash longer, your anxiety level is going to go up after that. And but it can't stay up forever. It's going to go up for 15, 20 minutes. And then as the hours and the days go by, nothing bad happens by reducing your hand washing drastically. If you take one obsession after another, or one compulsion to do some behavior, then the next one is easier to go away. And after a while, when you've rid yourself of a few of these, a number of them start going away on their own. So sometimes it can be an extremely effective therapy, and the cognitive behavioral therapists that do this can have a very high rate of response, and they can be more effective than medication, and the benefit will last longer than the medication. The benefit from the medication only lasts as long as you're on the medicine. And I have seen people that virtually lost all their symptoms with CBT therapy. And then they can go for months or years without it recurring. But when it starts to recur, they have to immediately go in and start to use the tools they learned in order to control the problem again. Now, the part of OCD where you're having thoughts going through your mind, this is harder. Like, I have a thought that taking extra calcium raises the risk of heart attacks. On the other hand, my doctor has told me that I have osteopenia and I need to take more calcium. So if I'm taking 1,000 milligrams a day of calcium, then I'm raising the risk that I'm going to have a heart attack and die. And then I can go through this in my mind over and over for hours and torture myself about whether I should take that amount of calcium or take less. Now, this is not something that you can control by, having the person sit on the couch, because they'll have the same thoughts there. So this is harder to treat with behavioral therapy, but it can be done. And not as successfully, but it can be done. And by the way, everybody should be on vitamin D, which is a steroid hormone to absorb calcium. And if you're on adequate vitamin D, then you don't need to take in a lot of calcium for your osteopenia, because you're going to absorb it from the intestine fine, and you don't need more than 500 or 750 milligrams a day of calcium if you're on adequate vitamin D. But adequate vitamin D is about 5,000 international units per day for an adult, and sometimes much more, up to 10,000. Depending on weight and so on. Now, when you use medication for OCD, about the best that happens is one has a 50% reduction in symptoms. The Y-box score, the Yale-Brown Obsessive Compulsive Scale. When research is done on OCD, it is called a response if the score goes down 25%. In depression, it's not called a response unless you go down 50%. And the reason is depression is easier to treat, and there's a fair number of placebo responders in depression. So you just don't count it as a good response unless you've reduced the score by 50%. But with OCD, it's much harder to treat. It's hard to get somebody over 50% improved, and there's hardly any placebo responders. So therefore, they use 25% as the cutoff for response. I have been treating OCD with TMS for some time, and I put together some of the statistics. I had no idea how we were doing exactly. And we've had about 20 patients that we treated. 18% of them improved between 54 and 67%. That is, 18% had an over 50% decrease in their score. And another 27% improved between 25 and 40%. And then another group improved 15 to 24%, which was significant. They could really tell the difference. And when you put that together, then that would mean that we had 53% of people who reduced their Y-box score somewhere between 15 and 67%. And that means that perhaps close to half of people didn't have any response at all, although this is a little confusing. I have to go over these numbers, but in any case, there's quite a few people that have done really well. And we're going to do more follow-up to see how long it lasted. It lasts a long time, the benefit of TMS in depression, and we're not as sure with OCD, but it seems to have also last a long time. One young lady that we did had a high depression score of like 35 MADRS and a Y-box of 23. And I believe that when you get up to 23, 24 on the Y-box, you're reaching a point where you can't function at work. And her depression score went down to 0. She became normal in mood for the first time in years. And this was a woman in her early 50s, a very intelligent, hardworking woman, but was tortured by these OCD thoughts all day. And her Y-box score went down to 10, so it reduced over 50%. And 6 months later, she was still down 50% and felt that she had gotten half her life back and was also being given a lot more responsibility at work because people just noticed how well she was doing. So I think it's an excellent treatment, and I think that a lot more people could get better if we could do enough treatments if someone isn't appreciably better in 30 treatments, it's better to go on and do 60 or more. And that would probably capture a lot more people. Also, there are some people who don't have an immediate response. One young lady who was only 22 and really had been tortured with this all her life, had about 40 treatments with absolutely no benefit to the OCD. And she had a type of OCD. It was so much torture that if she were driving a car, she would think maybe she had hurt somebody, and then she would have to turn around in the car and go back to check. So she had to stop driving the car. It was so unpleasant. The TMS worked very well for her lifelong depression, and it came down to normal. And it was a huge relief. And then a year later, her OCD was 50% better. And she said she thought it was because of no longer being depressed. She had the willpower and the energy to fight the OCD symptoms, and that's why it decreased. So I think the best treatment for OCD is probably to do all three things, because it's so difficult to treat, and each of the treatments does have a record of helping, and it'd be better just to do them all. Do cognitive behavioral therapy, get on medication that'll work, and to use TMS. And when people relapse, go right back in and do a few TMS treatments again. And the patient should also probably all be on 150 milligrams of lithium, 150 milligrams of lithium, because lithium helps out depression over the long run. And I now have, as of today, 55 people who became less depressed within 2 weeks of my adding just that tiny dose of lithium. And then there's many other people that improve as time goes on. This is Robert McMullen. I've just talked a little bit about treating OCD with TMS, medication, and cognitive behavioral therapy. Thank you very much.